The last presenter is Dr. Elly Odongo and Dr. Simon Kigondu. Dr. Elly Odongo was engaged in another activity, so was unable to come here today, but I'll just do the needful. The gyne-oncos, they have disappeared. They will be Elly Odongo. Gyne-oncos. So this presentation is a presentation of a client I co-managed with Dr. Elly Odongo. Dr. Elly Odongo is a gyne-oncologist at JKU. Kenyatta, Panda Bay, amekuja Kenyatta University. Kenyatta University and also in private practice. And we are in the same building, sort of at KMA Center, so it's easy to move the patient downstairs when we decide that we have reached the end of thinking capacity of a patient. So the title of the presentation, it's like a case report from first contact to precision care and what the role of the gynecologist is in endometrial cancer in the era of molecular classification. It was I'm able to move, huh? So the background to this, and we saw some of the presentations yesterday by Dr. Mbeneka, is that there is actually a rising burden of endometrial cancer. And early diagnosis is critical. In our group, you have seen the discussion between generalists. In fact, I have decided to run with this term, generalist gynecologists. In the era of more and more sub-specializations, the general gynecologists like us who don't plan to return to school anytime soon, except for leadership school, is taking shape, so to speak. So there is a role for generalists, general gynecologists, and generally they will be the first contacts to patients gynecological. If you go around the country, majority of the gynecologists currently would be the term generalist. So we've highlighted the collaborative care model in which gynecologists, one, initiate the diagnostic pathways, coordinate multidisciplinary referrals, and ensure that there is continuity of care. And this approach improves patient outcomes because it reduces delays in diagnosis and treatment. And a lot of these have been highlighted by some of Dr. Mbeneka's presentations. So we have a 63-year-old lady who presents with a history of vaginal discharge and vaginal bleeding. 63-year-old, postmenopausal, presents with vaginal discharge and vaginal bleeding. She reported that she had started getting the spotting that continued to increase. She had no abdominal pain, no backache, no cough, no diarrhea, no vomiting. And she had been postmenopausal for very many years. She was para 3+2. In 2022, a pap smear done was normal. This, we are seeing her in 2026. She reported that she had been on diabetic medication on and off. And she was not on follow-up by any physician. And occasionally she takes glucomet, one tablet once a day. It's not a story, nakuwa the typical story, Virena. She occasionally does self-blood sugar test, and the day before I saw her, her blood sugar was 13.4 grams per deciliter. And that did not seem to bother her, you know. No history of hypertension, and she had no known allergies. The operations she has had 2 cesarean sections before. She did not smoke, but occasionally alcohol on and off, beer. And the reason she took beer is because that she had heard that it was good for diabetes. When I saw her in the first examination, her blood pressure was 142/78. She was 104 kilos. She had normal temperature and a normal pulse. She was in fair general condition. She was not pale and had no edema, but she was obese. Breast examination was normal. Abdomen had a subumbilical midline incision scar from the 2 cesarean sections. A vaginal exam done showed normal external genitalia. There was a slight discharge, no obvious mass. I took a pap smear. And an endometrial curettage using the small MVA cannula. Remember our discussion yesterday? In the office, and again, yeah, you can actually do this in the office. It really saves, there's a cost element in terms of theater, but sometimes you may need to do it in theater if, cervix, maybe people have had cesarean section, cervix closed, so it depends. So if you can do it in the office, then use the smallest MVA. As we had the discussion yesterday, the MVA kit tends to have a lot of pressure and can take quite some good tissue. Imaging was done, and it showed endometrial thickness. From the biopsy done, the endometrial curettage, the diagnosis came as serous cancer of the endometrium. And that was the end of the generalists. That's hapo ndio tumefika mwisho. So I referred to the gyne-onco. These are the things to do. So gynecologist, diagnosis, then refer. The gyne-onco proceeded and did definitive surgical management, which included a total abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, pelvic lymph node dissection, and surgical staging was completed. The histopathology report and the molecular classification was as follows: serous carcinoma high grade, less than 50% myometrial invasion, LVSI present, node positive. Based on TCGA, tumors are categorized into pole ultramutated, mismatch repair deficient, P53 abnormal, and no specific molecular profile groups, NSMP. See why you need gynecologists. The present aligns with P53 abnormal subgroup associated with aggressive behavior and poorer prognosis. Lakini sisi Mungu, so prognosis nowadays you treat and wait, follow up the patient. Because of this, surgery was planned on adjuvant treatment, and the patient was reviewed and recovered very well post-op. They were appraised of the results in a family conference. Planned adjuvant treatment was carboplatin plus paclitaxel, 6 cycles, pelvic EBRT, brachytherapy, and the treatment strategy was a sandwich approach or concurrent chemo radiation. Protect 3 evidence, chemo radiotherapy versus RT. Improved survival in this stage are key for Sarah's histology. The patient is currently on maybe the 2nd cycle and is doing well. So we brought this case up to show that gynecologists play an indispensable gatekeeping role. Yeah? And early diagnosis and timely referral, combined with emerging molecular stratification, are key to improving outcomes and advancing precision care in endometrial cancer. Thank you very much.
Thank you for the